Hello, and thank you for joining us this evening for Webinar 3. There's a person behind every prescription. Before we begin, we have a couple of reminders. If you're experiencing any technical issues, please email communications@bcpharmacist.org. We also wanted to let you know that the presentation portion of this webinar is being recorded and will be shared and posted on our website after the session. Our 2 introductory webinars are available online as well, and future CIRCL webinars will also be posted. If you haven't attended live, we encourage everyone to watch those. On a personal note, in case you're in the same boat as many of us and need to complete CE for our upcoming renewal deadline at the end of March, you can count the time spent on these webinars towards your requirements for non-accredited CE. I just got my reminder. I logged in to get started. March 31st will come up quickly, so I encourage you to do the same. Lastly, if you'd like to submit a question for the presenters, please click on the Q&A button at the top right-hand corner of your screen. For those of you joining from a mobile device, it might be at the bottom of your screen. Please note this is separate from the chat button. Q&As about the presentation will be answered at the end of the webinar, but we encourage you to enter questions as we go along, and we'll try to sort and get to as many of them as we can. You can also email the college directly with general questions about CIRCL. As we get started, I'd like to acknowledge the rights and title of the First Nations on whose collective unceded territories the Office of the College of Pharmacists of British Columbia, where I'm presenting from today, is located. These are the homelands of the Hunkaminam-speaking peoples in the territories of the Musqueam and the Tsleil-Waututh Nations, and the Squamish-Snatcham-speaking peoples of the Squamish Nation. These nations have existed here for over 9,000 years, and we continue to support their inherent rights and title to these lands and waters. In recognition of our role in serving people and communities across the province, we also acknowledge the rights and title of over 200 First Nations whose collective unceded territories stretch to every inch of what is now colonially known as British Columbia. As leaders in the settler health system, we acknowledge our responsibilities to uphold the inherent and enduring rights of Indigenous peoples across Canada under international, national, and provincial law. Just as a reminder about CIRCL program timelines, currently we're in the transition period and full implementation is required by June 1st, 2026. That's the date when all the requirements will come into effect for every pharmacy in British Columbia. When we do our inspections, that's when we'll start ensuring that pharmacies are meeting CIRCL requirements. To help you prepare during the transition period, we've developed resources that are now available on our website at bcpharmacist.org/CIRCL. These include an overview of the program and key requirements, guidance on selecting a reporting platform, implementation steps, best practice guidance, and frequently asked questions. We've also recently developed a quick start guide. All of these resources are there to support you and your team in putting the new standards into practice. So this is the third in a series of webinars to help you prepare for CIRCL. Our next session, Webinar 4, will be held in May 2026 and will be the final webinar before the CIRCL implementation date. Each webinar builds on the last, giving you more detail, practical guidance, and time to ask questions as we move closer to full implementation on June 1st, 2026. Today's webinar will be hosted by the Institute for Safe Medication Practices Canada, or ISMP Canada, and led by Melissa Sheldrick, who is ISMP Canada's first patient and family advisor. Melissa brings a powerful lived perspective to medication safety advocacy following the loss of her son, Andrew, due to a dispensing error involving compounded medication. Since 2019, Melissa has worked nationally and internationally to advance medication safety by sharing her experience and calling for meaningful system-level change. Her work reminds us that behind every prescription is a person, and that learning and accountability are essential to medication safety. Melissa is joined tonight by her colleague, Enna Aujla, Director of Community Pharmacy Reporting and Learning Program at ISMP Canada, who will share her experience as a pharmacist in connecting CIRCL to practice. Before I turn it over, I want to thank ISMP and Enna for partnering with us at the college and supporting the launch of the CIRCL program every step of the way, and Melissa for sharing her story with us tonight. Melissa, you've actually come full circle with us, as all of this began when you first came to talk to our board in 2017. That's almost 9 years ago. Thank you for helping us get here. Your story underscores the essence or the why we're doing this. So on that note, over to you.
Thank you so much, Ashifa, and thank you to the whole team for having me here and putting this together and allowing me to share this important message with all of you who have taken time out of your evenings to join us. So thanks to all of you for being here. This is a brief agenda of what we're going to look at for the evening. I'll share my story. We'll talk about building a culture of safety and what that looks like. Some more information about continuous learning and incident reporting, and then the importance of patient engagement. We can go to that. Thank you. I'm happy to share some family photos with you, things that I hold near and dear to my heart, and really pleased to be able to let you in on a little glimpse of who Andrew is, which you'll see a little bit of that in our next slide. Andrew was a very typical, busy little boy. He loved water. You can see from that bottom picture. If there was water, he was in it. He also loved sports. He had his Blue Jays jersey on in that picture, and there was always a ball under his arm, no matter where he went, and loved soccer the most. He had learned some soccer skills and was busy learning that. And he was a shy and sensitive, but caring and empathetic little boy. And his friends and his teachers knew it. I like to share a story. There was a little boy in his class who was having some really difficult days. And this one particular day, the teacher couldn't calm the boy down. And Andrew saw this and he sensed it, and he went up beside him and he said to him, "Hey, dude, you look like you're having a bad day. Do you want to go play?" And the boy just calmed down, and off they went with their soccer ball to the field. And he made such a difference in that little boy's life. And so that's really the essence of who Andrew is, and why I think sharing his story has been so powerful over these past 9 years. Next Friday actually marks 10 years since we lost Andrew. And so it's, to see how far regulators and pharmacists and pharmacy technicians have come over this time is really a beautiful thing to see in his memory. Andrew developed normally. When he was about 5.5, he started experiencing night terrors, and he would have a hard time falling asleep, and he would wake up in the night screaming and then not remembering what had happened in the night. And we spent many months trying to figure out how to help him. And we went to all kinds of different doctors and all kinds of allied health professionals. And finally, we were sent for a sleep study. Andrew received a sleep diagnosis of parasomnia. And this is a sleep disorder, and parasomnia is all the abnormal things that happen to somebody when they sleep. And in Andrew's case, he went into his REM sleep cycle twice as quickly as normal. And so it's a sleep cycle. So once you disrupt one cycle, you disrupt all of them. And so, with that diagnosis, the doctor then recommended that he take tryptophan to try and regulate those sleep cycles. And that was a dose of 5 tablets per night. Now, as many of you know, these are large, white, chalky tablets that, as for a 6-year-old child, we were having to crush them every night and mix them, and we were trying to get him to take it, and it was a bit of a rigmarole. So when I spoke to the doctor again, I asked if it came in a liquid form, and they said no, but you can have it compounded and see if there's somebody who could do that. So I didn't know what compounding was at that time, and I did my research and looked it up and found the pharmacy closest to home and took it to them, and they said, yes, we can do this. It has to be refilled every 2 weeks, and you have to keep it in the fridge. And this was incredible. It really was the answer, because what we had noticed, even with the tablets, was the difference in his sleep cycles and the difference in his quality of sleep. And it made an impact on his daily life and his life at school. And it made it easier for him to go back to go to sleep in the evenings. So to be able to have it in a liquid dose like this was just excellent. So we did that for 18 months. He received this compounded medication, and we refilled it, and then we picked up a refill. This was in 2016, and I gave him the first dose out of the bottle and tucked him into bed, and then he didn't wake in the morning. And we just had no idea what happened. We had no idea how he went to sleep and died in the night. We asked a lot of questions, but had zero answers. And it wasn't until July of 2016 that we were told that the bottle of medication that they took from our fridge that Sunday morning had no tryptophan in it whatsoever, but contained only baclofen, mixed in the same concentration as his tryptophan, which was 3 times the lethal dose for an adult. So it was a massive overdose, and it just made us, well, it made us angry, and it made us question why and how, and what do you mean medication errors happen? They told us, medication errors happen, and and this is common. And thankfully, they're not harmful most of the time. Many times they're caught, so they don't reach the patient at all. But sometimes one gets through and there are devastating consequences. So I wondered then, what's going to come of this? I was of sound mind enough to know that I couldn't undo what had been done. And so I had to look forward and do what I could to prevent this from happening to anybody else. So I called attention to it in the media. And I asked that we meet with our Minister of Health in Ontario to mandate that a CQI program be put in place in Ontario to include the reporting of the anonymous reporting. I stated that from the outset of errors and near misses for the collection of aggregate data, so that we can look and see what's happening on a system level and target what those fixes might be, and what are the wins that we could find from a higher level so that these errors don't get through to people. And so we were really privileged to be able to go and meet with the health minister, and he was incredibly supportive. He did say that this was under the purview of the Ontario College of Pharmacists, and so he put me in contact with them. And they really stepped outside the box and they called me and they said, you know, we've never had a member of the public on a task force like this, but we want you to come and be part of this, to build this program and to really bring the why, which is why I'm here with you today as you launch your CIRCL program in June. So we created the AIMS program, Assurance and Improvement in Medication Safety, and it is a standardized medication safety CQI program with these 4 pillars of report, document, analyze, share, so that what's being learned from these errors and the analysis of these errors is not lost and it's put forward for preventative purposes. And I do also like to share that the A and the S are in dark blue because those are Andrew's initials. So when I started all of this work, I learned that only Nova Scotia had this kind of a quality assurance program in place, and they were reporting. They were reporting robustly, and there's data out there from those Nova Scotia pharmacies in those first 7 years. And I thought to myself, well, if Nova Scotia can do this little province in Atlantic Canada, why aren't the rest of the provinces doing this? And that started my journey. And so I went province to province to province, by email, by phone, by plane, by Zoom, and however I could get my message out, I did that. And I am so grateful and so proud to say that in 2026, this map is almost completely green. And we are seeing these programs in place across the country, and pharmacy staff are responding beautifully to these programs and are reporting and are taking those learnings and implementing strategies to keep their patients safe. And so I've had the opportunity to engage with regulators in different ways. So you can see some of them here. Like I said, with the AIMS program, I was involved from the very beginning. Um, in Manitoba, I helped to co-design a toolkit for community pharmacists who were just coming into their Safety IQ program. CQI Plus here in Alberta, um, that just launched February 1st, and I was part of a patient working group so that we could, as patients, help inform the college what's important to patient safety for this program moving forward, and other communications with Nova Scotia and with all of the provinces. They've been incredibly receptive to my story and to the words that I have to say. So this collaboration and engagement was part of the regulators building a culture of safety. And so I want to dig in a little bit to what that actually means. So building a culture of safety is really about creating a space for learning. Errors, and especially near misses, are about the prevention of harm. It's never about blame. It is never, should never be about punishment, but accountability, yes, and knowing and doing better. And this word reporting can have a negative connotation to it, but it really is a key part of that safety culture. And historically, we know that there's been finger pointing associated with reporting. But the WHO says that health systems face difficulty in establishing a safety culture that's based on blame-free reporting, in which learning is more powerful than judgment. And that's really the focus that we want to take with these CQI programs like CIRCL. And so with all of your help, the college is going to evolve that word reporting to be known as learning. This is very much a commitment and a shift in thinking and perspective from all stakeholders. So let's look at some of these words that we associate with the components of building a culture of safety. You see these words: education, just culture, learning, teamwork, etc. They're all part of it's just the way we do things around here. Safety should never be an add-on. It should be embedded in workflow and certainly in a mindset. In the book, option B, they say that when it's safe to talk about mistakes, people are more likely to report errors and less likely to make them. Yet typical work cultures showcase success and hide failures. Teams that focus on learning from failures outperform those who don't, but not everyone works in an organization that takes the long view. And so this notion that performance, and in our context, safety is improved is critical. This isn't a quick fix, right? But it requires the focus, it requires the commitment of everyone, including dedicated resources to build a safer environment for patients and also for all of you as staff. So one important aspect of a safety culture is a just culture, right? This is based around justice, where the outcome or the severity of an event should never determine the response to individuals in that event. And you can see some key components of a just culture, right? Systemic issues, you have support provided. We're focusing on understanding and not blame. We're looking at the differences between human error and deliberate actions or unprofessional conduct. And this focus on system level learning is key to a just culture. There is a QR code there, and I have provided a link for you to a free e-learning module. It's about 20 minutes long, was co-designed by ISMP Canada and Health Quality Alberta, really digs into just culture, and I would encourage you to learn more through that e-learning module. So psychological safety is another important part of a safety culture, right? This is the belief that no one will be punished or humiliated for speaking up with ideas, for talking about a mistake that they made, for identifying a risk. Having an open conversation environment where discussion and communication is for learning is really key to having psychological safety in an environment. Dr. Amy Edmondson is a leading voice in the importance of psychological safety, and there's a QR code link there to a TED Talk. She talks about the correlation between psychological safety and medication error reports. And so I would encourage you to brew a cup of tea or coffee and have a watch of that video, because it's quite excellent to see her research findings. So when psychological safety is present, it impacts not just patients, right? We're talking about psychological safety for patients and families, but also for staff. It's really important that we work to have this kind of environment so that people can feel heard and respected and involved. That when they have a question, when they have a concern, when there's some kind of uncertainty, they feel confident that they can speak up, that they can ask those questions and not worry about humiliation or being put down or anything like that. And also that, we know psychological safety is present when medication errors and near misses are identified and learning comes from them. But when it is absent, well, people shut down, right? And they hesitate to speak. Sometimes their concerns are dismissed. Sometimes they're made to feel less than. They are humiliated. That's when, blame can come in and shame. And then, when you think about people who don't speak up and errors and near misses don't get talked about and questions don't get answered, that's when harm can happen. And so we want to avoid having environments where people are afraid to speak up, because otherwise there's just no way of knowing truly what is happening in that environment for staff or for patients. So creating these safe spaces for people means acknowledging power imbalances. We know that there's hierarchy, and hierarchy is not necessarily a bad thing until the power is imbalanced. And so we have to acknowledge when that's happening and work to rectify it. right? Creating a space where people can ask questions. When you are counseling your patients at pickup, do you have any questions? Do you have any questions about the interacts with food or your other medications? Or, how else can is there any other information you need to know? When it comes to disclosing any incidents or apologizing, part of my work at ISMP Canada is hearing from the general public who can report their medication errors to our website, mederror.ca. And so many times I hear about communication breakdown when they discuss a wrong prescription that they've received or a mistake with their prescription. And so that disclosure piece, that apologizing piece is so key to having a safe interaction and a trustworthy and a relationship building interaction. And then always responding with empathy and working to restore trust, and then thinking about ways to increase engagement, whether it's with staff or whether it's with patients. And this is the list from last year from ECRI. ECRI is an American, they are in Canada now too, but this is an American publication that came out last year, and this is the top 10 patient safety concerns of 2025. And you can see that number one is the risks of dismissing patient, family, and caregiver concerns, because there have been so many cases where people are not being listened to, they're not being heard, they're not being given time to have conversations or ask questions, and it's causing harm to people. And interestingly, number 10 on this list is deteriorating community pharmacy working conditions that contribute to medication errors and compromise patient and staff safety. And so, there must be an absence of psychological safety. And you can see the connection between these two because, um, community pharmacy is based around your patients. It's based around the people that you are looking after. And so, these are really key. This is a key document for you, and I've linked it there for you to have a look at. And interestingly enough, the top 10 for 2026 is actually coming out next week. So let's dive in a little bit more to patient engagement and why is it important? Why are we talking about this as we launch a CQI program for pharmacy teams? This framework highlights the different ways and the different depths that providers can engage with patients. There might be opportunities in your pharmacy that go beyond counseling or double checking medications. Maybe you see room for improvement in a particular patient experience area of your pharmacy. I would encourage you to engage with your patients, learn their perspective of the process, ask them how this is going for them. What are they seeing that could be improved? Sometimes that can be a scary question to ask, but it's an important question. They walk through every step of the process, so they have a really unique viewpoint to share their perspective. And perhaps they would pick up on things that you might otherwise overlook. And one of the things I speak to a lot of pharmacy students and pharmacy technician students as they're just starting in on their careers. And one of the things that I tell them is that you can't learn what I've lived. And I have viewpoints from my whole journey that um, it is not found in a textbook. And so when you ask people questions and when you learn from them and when you're open to be able to do that and build those meaningful conversations, your work will become richer, it will become better quality, and it will become safer. And so, engagement really is a key piece in building a culture of safety and establishing trust and a relationship with people for whom safety has the greatest impact.
Thanks, Melissa. So let's talk a little bit more about continuous learning. Safety in your medication systems should be assessed after a medication incident has occurred. This is a reactive approach, but we can also take a proactive approach through the process of safety self-assessments. A culture of safety is essential when conducting a self-assessment. Since self-assessments are designed to identify vulnerabilities in the medication management process, people need to feel safe when bringing forth their concerns, when raising awareness, and when recommending strategies to avoid harm. Maybe some background information here to help put this in perspective for all of us. Over 600 million prescriptions are dispensed annually in Canada. Medication safety directly translates to patient safety. Through analysis, we can say that unsafe medication practices and medication errors are a leading cause of avoidable, and I really want to emphasize the word avoidable here, a leading cause of avoidable patient harm that is estimated to have a global cost of $42 billion annually. So that was globally, but let's consider the Canadian context. In 2024, the top 3 types of incidents reported to the National Incident Data Repository, or NIDR, from community pharmacies were incorrect dose or frequency, being number 1, followed by incorrect quantity and incorrect drug. In 2024 alone, the top 10 types of incidents totaled over 24,000 reports, but just the top 3 types of incidents totaled more than 13,000 reports. Can you imagine if we focused our safety efforts on just the top 3 types of incidents, we could reduce the number of medication incidents by 50%. So these are the top 10 types of incidents reported to the NIDR in 2024. These include both harm and non-harm related incidents, and I just mentioned the top 3 on the previous slide. Some of the other types of incidents include incorrect patient, incorrect prescriber, omitted medications, and other types of errors. But I want you to think a little bit about this, that harm has generally referred to physical harm, and I want you to consider that non-harm reports could still mean a patient has experienced harm in some way. It could be psychological harm, such as the loss of confidence in their therapy, or they could experience financial harm because they had to take a few days off work. The definition of patient harm is evolving, so I want you to keep that in mind. What about hospital pharmacy incidents? Well, how does hospital pharmacy fit into the national landscape? Hospitals report into NSER through BC Patient Safety and Learning System, and this database has been with the Canadian Institute for Health Information, or CIHI, as you may know it. The NSER database will now feed into ISMP Canada, which means there is more opportunity for alignment and consistency between community pharmacy data and hospital pharmacy data. BC is at the forefront and leading the way for hospital reporting into NSER for the purposes of shared learning nationally. Back to Melissa.
Thank you. This image is adapted from the Canadian Incident Analysis Framework, and the full infographic is linked for you in the QR code. But this image gives you a brief look at what the framework is and the steps that are required to complete an incident analysis. And I'm here in Calgary for a workshop, and we've been discussing incident analysis and frameworks, and really moving the focus into contributing factors in that system level view. And so when you identify those contributing factors that led to an incident within the analysis process, you can then target the specific actions that you can follow through on to close the gaps and then be able to share the learning. So that analysis cycle is really important, and the learning that comes from it is ongoing. ISMP Canada did a comprehensive incident analysis for Andrew's case, and it is there in our safety bulletin in 2017. But the learning is ongoing. We publish actionable evidence-based recommendations at systems levels for multiple stakeholders. And when this bulletin was completed, when the analysis and the bulletin were completed, one of the recommendations that came from one of the contributing factors in Andrew's case was around improving the labeling of the repackaged active pharmaceutical ingredients that was used in the compounding of his medication. So we led a pan-Canadian roundtable of compounders, regulators, safety organizations, and manufacturers to establish considerations for safer labeling. And that really, that was done in 2022. And I really like to highlight how recommendations that are published, they don't all have to be done right at the same time. And some of them might take more resourcing to do, and some of them might take more time. But that learning is there, and we don't want to lose it because it is so valuable. One of the other publications that we do at ISMP Canada is our consumer publications. And so our consumer team decided to share learning to parents who have to have their children's medication compounded with safety tips for them, and knowing which questions to ask. And this resource would have been really helpful to me. And so this is just one example of the longevity of the information that's discovered during the analysis process, and the continuous improvement that it enables. And although analysis processes take time, which they do, they take dedicated resourcing. There's so much value in that information, and value that's not lost, and can be acted upon over time and then shared with others, right? That's such an important part. Our at ISMP Canada, I'm sure you've heard us talk before about our Learn, Share, Act cycle. And so sharing that information to be able to act on it is really important. So all of this work that we're talking about has to be done through a systems approach. I mentioned earlier that focusing on what a person did wrong or assigning blame is ineffective. Telling someone to be more careful doesn't work. Telling somebody to look both ways before they cross a highway isn't going to work, right? So we really have to shift that person approach to a systems approach, and let's look at it from a higher level and strengthen those components around the people who work within them. And so just as there are contributing factors that lead to an incident, there are factors that can be bolstered to prevent them. So this model of patient safety comes from James Reason, and it really exemplifies this notion of contributing factors. So these layers of Swiss cheese in Reason's model of patient safety are those contributing factors. But these holes in the systems, they're not stagnant, right? They're always moving. For example, we see that, one of the contributing factors could be around um, staff shortages around the team. Maybe your team's out with the flu and you're short-staffed. And so you get through the day, hopefully no errors have happened. And the next day your team is back in full force, but your technology bottoms out. And so then that's another hole that's emerged. And so when all of these holes line up, as sometimes they do, that's when the harm gets through. Thankfully, we have these systems, and once we bolster them, they can prevent those harms from getting all the way through.
So let's dive into the practical application of what we've been talking about today. Let's acknowledge that talking about medication incidents can be hard. Talking about medication incidents that have happened in our pharmacies, incidents that may have gotten past you or your team, incidents that have caused harm to a patient, these are important conversations because the patient is at the center of why we do what we do. So let me start this conversation between us today. Let's try and make this conversation a little easier going forward for all of us. I have a question for all of you. Have you ever been involved in a medication incident? I have. After listening to Melissa and Andrew's story, how many of us thought, well, this is sad. This is so sad, but this is unlikely to happen in my pharmacy. We have good processes in place. We have good people in place. Well, before an incident occurs, we need to be talking about patient safety in our pharmacies, and we need to be embedding safety considerations into our processes. So remember the Swiss cheese model? I want to share with you a day where all the holes lined up for my pharmacy, where I was a new pharmacy manager. A young child had been receiving refills of compounded clonidine from the pharmacy for quite some time. After receiving one dose of the most recent refill, the child became extremely drowsy and unstable, and the child was taken to the hospital where it was determined that they were likely presenting with clonidine toxicity. As a pharmacist and as a parent, the feeling was overwhelming. I needed to find out exactly what had happened and to ensure it never happened again. Questions came flooding forward, which I'm sure come flooding forward for all of you when you experience an error in your pharmacies. How do I approach this problem? What can I change? What are my resources? How do I create an environment of continuous quality improvement? We needed to formulate a plan moving forward to improve processes within that pharmacy and to ensure patient safety. We also needed to support the pharmacy team, and we needed to ensure business sustainability. So what steps did I take? I followed the Canadian Incident Analysis Framework, which helped me take a systems approach to the problem. The first step in the framework was to provide an immediate response and patient support. I provided all the information I could to the parents and the physician to support the patient's recovery. An initial review of the documented calculations and weights didn't reveal any obvious errors. We needed to dig deeper to understand what happened. And while we did this, we outsourced all our compounding for children and any compounds with APIs with a narrow therapeutic window. Now that we had mitigated the risk of recurrence through outsourcing, we followed through on the remaining steps of the investigation. Sharing the findings, making system improvements, including evaluating the changes to ensure our patients were safer. The pharmacy staff had been compounding for many years, and I was a new leader to the team when the error happened. Safety culture was a key focus through this whole process. An analytical assay of the compound later revealed that the preparation contained approximately 10 times the labeled concentration of clonidine. On the next few slides, I'll dive in a little deeper about what the analysis revealed and how I followed through and closed the loop. So we conducted an audit of the weight of the clonidine on hand to determine if there was a weighing error. We reviewed calibration records for the weigh scale to investigate if perhaps there was an equipment failure. All compounds prepared over a period of days before and after the compound were reviewed to determine if cross-contamination may have been a contributing factor. And finally, a review of any other recent error reports and documentation from other prescriptions made from the same API. Team management was a critical step in this process, and safety culture was a key focus during the meetings and discussions. So what did the analysis reveal? What were the contributing factors? First, there was an inadequate standard for a final check process, which should have included a process for an independent double check by a pharmacist during preparation. This was a key contributing factor, which resulted in an incorrect reading of the clonidine weight by a non-pharmacy registrant, resulting in a missed decimal point on the weigh scale. Second, there was incomplete documentation of clonidine compounds, which made it difficult to backtrack the steps, and it was somewhat challenging. Third, a culture of safety was not really well understood by the staff to facilitate reporting of errors and to focus on designing a safe system to proactively assess the daily risks inherent in the operations of the pharmacy. Fourth, a lack of policies and procedures which incorporated the NAPRA model standards for non-sterile compounding meant different staff members were preparing the compound in different ways. And lastly, there was a lack of familiarity or training with the preparation of the compound by the staff member preparing the compound. We needed to build a culture of safety where we were thinking about the system, where things could go wrong, and where the holes in the cheese might arise in the process. This needed to be front and center for everyone on the team. So how did we close the gaps? And when I say we, I do mean the entire team because the change required the entire pharmacy team. The solutions we implemented included growing a culture of safety through education with the pharmacy staff. A discussion on the incident itself was conducted, education on changes and policies and procedures, and regular safety huddles occurred. We also identified training opportunities and conducted regular skills assessments of staff for high-risk processes. Next, we designed a system whereby a pharmacist performed independent double checks for the ingredient CAS numbers, for weight verification, and for the compound calculations. We used technology to reduce the risk of another error or confirmation bias when reading the scale. So we purchased a weigh scale that printed out the weight of the ingredient to be included as part of the prescription documentation. We also ensured we minimized distractions to the pharmacy staff when engaged in high-risk processes. And lastly, policies and procedures were created, which included the NAPRA model standards, and we did this by enlisting the services of a compound subject matter expert. The final step in incident reporting and learning is closing the loop, sharing what we learned internally and externally. The analysis and the system-based changes were shared in this safety bulletin. Clonidine compounding errors continue to harm children. A question I sometimes ask myself, if the team had read about previous clonidine compounding errors, could this error have been prevented? Maybe. This is how learning across the country gets back to you as pharmacy professionals. So back to the Swiss cheese model. We're talking a lot about cheese tonight, but I'm going to ask each of you to imagine a day in the life at your pharmacy. First hole, maybe it's been a while since your pharmacy's policies and procedures have been updated. Second hole, perhaps we've recently hired a new staff member and we've not yet had the chance to provide adequate training because we had another staff member sick. Third hole, technology is failing. The barcode scanner has been acting up and is not working at patient pickup. Fourth hole, distractions. The phone has been ringing off the hook with questions for the pharmacist. I would venture a guess that many of you can relate to some of these, if not all of these. Today could be the day that the holes line up for you. The circle that ties everything together that Melissa spoke about today for all of us here in BC is this one, continuous improvement. Melissa spoke about collaboration and engagement. Regular team meetings can only be successful if team members feel there is a safety culture that allows them to speak up without fear or reprisal. Learning from reporting can only happen if we shift from a person approach to looking at a systems approach when striving for quality improvement. As healthcare professionals, we may default to thinking that collaborating is just about our own local team or with other healthcare providers. Collaboration also includes open disclosure with patients so we can gain insights from the patient's perspective. To sum it all up or come full circle, as Melissa first said, and as the Shifa first said, there is a person behind every prescription. My call to action to each of you is to evaluate your systems, find the holes in your cheese slices, and make system improvements to work towards zero preventable harm from medications. Thank you to the College of Pharmacists for allowing Melissa and I to come and share our stories with you today. And thank you for attending tonight.